So we have deal with primary glaucoma. Now we will start secondary glaucoma, which is associated with primary ocular disease or systemic disease. It is subdivided into angle closure and open angle. Secondary angle closure further divided into pupillary block and without pupillary block. So with pupillary block there is seclusive pupillae. Seclusive pupillae means 360-degree posterior synechia, usually secondary to recurrent iridocyclitis. So this is one cause of secondary angle closure glaucoma with pupillary block. And there is subluxated lens. It can cause pupillary block. Pacomorphic glaucoma, it can also cause secondary block. Capsular block syndrome with 360-degree iris capsule adhesion in pseudopachic eye. So when iris and capsule are attached, this is called capsular block syndrome. Apachic pupillary block and anterior chamber lens implant without a patent iridotomy. This can also called angle closure glaucoma. Another type of secondary angle closure is without pupillary block. There are a number of causes. The first cause is secondary causes of peripheral anterior synechia, such as occurring in neovascular glaucoma, advanced neovascular glaucoma, and chronic anterior uveitis, cilio-choroidal effusion, capsular block syndrome without iris capsule adhesion, ciliary body iris cyst or other ciliary body or posterior segment tumor, contraction of retrolenticular and fibrovascular tissue, contraction of retrolenticular fibrovascular tissue such as in proliferative vitreoretinopathy and retinopathy of prematurity, and the last is malignant glaucoma, also known as ciliolenticular block. So now open angle secondary angle closure glaucoma, secondary open angle glaucoma. So one is secondary closed angle, this is secondary open angle. Secondary open angle glaucoma can be subdivided on the basis of the site of aqueous flow obstruction. Like the aqueous flow may be obstructed pretrabecular, trabecular, post-trabecular. So pretrabecular, there are three causes. Pretrabecular, in which the aqueous flow is obstructed by a membrane covering the trabeculum. It may consist of fibrovascular tissue, which occurs in neovascular glaucoma. So neovascular glaucoma can be open angle, secondary open angle, and also, as we have said already, it can be secondary closed angle. So here we said it is in closed angle, secondary closed angle, it was also a cause, neovascular glaucoma, which cause peripheral anterior synechia. So it can cause closed angle as well as open angle. And there is endothelial cellular membrane proliferation, also known as iridocorneal endothelial syndrome. And there is epithelial cellular membrane proliferation, like also known as epithelial ingrowth. So these are the causes of pretrabecular open angle, secondary open angle glaucoma. And there is trabecular. Trabecular, in which the obstruction occurs as a result of clogging up of the meshwork and secondary degenerative changes, like pigment particles in pigmentary glaucoma. So pigmentary glaucoma is a open angle glaucoma, secondary open angle. Degenerated red cells, host cell glaucoma. Macrophages, lens proteins in pacolytic glaucoma. Proteins, probably an element in hypertensive uveitis. Pseudoexfoliative material in pseudoexfoliative glaucoma, which we will discuss after this topic. Trabecular glaucoma may also be caused by alteration of the trabecular fibers themselves by edema in trabeculitis in hypertensive uveitis, or scarring like post-traumatic angle recession. So this can also cause open angle glaucoma. Post-trabecular, in which the trabeculum itself is normal but aqueous outflow is impaired as a result of elevated episcleral venous pressure, like in carotid cavernous fistula, Sturge-Weber syndrome, obstruction of the superior vena cava. Pseudoexfoliation glaucoma or pseudoexfoliation syndrome. Pseudoexfoliation syndrome, it is actually an ocular manifestation of a systemic disorder, and it is the commonest cause of secondary open angle glaucoma. So age-related multifactorial progressive disorder. There is extracellular material which cause white fibril deposits in the eye, blood vessels, skin, gallbladder, kidney, lungs, and also in the heart and meninges. So it is commonest cause of secondary open angle glaucoma. It is easily overlooked in the early stages as the signs are not always obvious. It is rare before the age of 50 years, but the prevalence increases rapidly after the sixth decade of life, with a prevalence of 5% at age 75 to 85 years. And it is more common in women than men, and although the condition is found worldwide, the prevalence is highest in Scandinavia. Not all patients with pseudoexfoliation syndrome will develop glaucoma, and there is no reliable method of determining which patient with the condition will subsequently develop optic disc damage. Incidence of pseudoexfoliation glaucoma at diagnosis of pseudoexfoliation syndrome is 15 to 30%. The cumulative risk of eyes with pseudoexfoliation syndrome requiring glaucoma treatment may be as high as 60% at 5 years. It should be distinguished from true capsular exfoliation, which occurs secondary to chronic infrared exposure, glass blower cataract. Pathogenesis. Pseudoexfoliative material is a gray-white fibrillary substance derived from abnormal extracellular matrix metabolism in ocular and other tissues. The material is deposited on various ocular structures, including the lens capsule, the zonular fibers, the iris, the trabeculum, the conjunctiva. Pseudoexfoliative material has been found in the skin and visceral organs, leading to the concept that pseudoexfoliation syndrome is the ocular manifestation of a systemic disorder. Pseudoexfoliative syndrome is associated with an increased prevalence of high-tone hearing loss and cardiovascular disorders. Pathogenesis is multifactorial, but in some population, almost all patients with pseudoexfoliation syndrome have a single nucleotide polymorphism in the LOXLI gene on chromosome 15, which codes for an enzyme that is involved in cross-linking of tropoelastin in collagen and is therefore important for the formation and maintenance of elastic fibers and extracellular matrix. However, these SNPs are common in the general population, and most individuals with SNPs do not develop pseudoexfoliation syndrome. Plasma and aqueous humor homocysteine levels tend to be higher than controls, and inadequate dietary folate intake. Folate reduces homocysteine. So inadequate dietary folate intake may be a risk factor. Open angle glaucoma, sometimes termed as capsular glaucoma, is usually due to elevated IOP secondary to trabecular obstruction by pseudoexfoliative material, and the open angle glaucoma, sometimes termed as capsular glaucoma, is usually due to elevated IOP secondary to trabecular obstruction by pseudoexfoliative material and liberated iris pigment, leading to secondary degenerative outflow dysfunction. Curiously, despite the systemic nature of the condition and the fact that biopsy reveals subclinical pseudoexfoliative material in the apparently unaffected eye, glaucoma remains confined to one eye in about 2/3 of patients. Clinical features diagnosis is usually incidental but can follow vision loss from advanced glaucoma. On the cornea, the pseudoexfoliative material may be deposited on the endothelium, and scattered pigment deposits are common. A vertical spindle, also known as Krukenberg spindle, may rarely form, similarly to that seen in pigment dispersion syndrome. Endothelial cell abnormality such as low density is more common than average. Anterior chamber pseudoexfoliative material particles are sometimes seen. Mild aqueous flare from an impaired blood aqueous barrier is common. In the iris, the granular pseudoexfoliative material deposits. There is pupillary rough loss and patchy transillumination defects at the pupillary margin. In the lens, the anterior lens capsule typically shows a central disc and a radially indented peripheral layer of pseudoexfoliative material separated by a clear zone maintained by pupillary abrasion. Peripheral capsular deposition is often visible only with pupillary dilatation. Deposits may be flaky with scrolled edges. Cataract is more common in an eye with pseudoexfoliative material, probably because of reduced ascorbate levels in the aqueous. Pectodonesis is the lens instability due to zonular weakness may be present, but spontaneous subluxation is rare. Anterior chamber angle. There is patchy trabecular and Schwalbe line hyperpigmentation. It is common and especially inferiorly. A Sampaulissi line, which is an irregular band of pigment running on or anterior to Schwalbe line, is commonly seen. It is not pathognomonic and can be found in pigment dispersion syndrome, as you can see in this picture. There is a dandruff-like pseudoexfoliative material deposits may be seen. There is an increased risk of angle closure, probably because of zonular laxity. In most eyes, the presence of glaucomatous damage is associated with elevated IOP. The majority of patients have a chronic open-angle glaucoma that is usually unilateral at first. Occasionally, the IOP may arise acutely despite a wide angle, mimicking acute angle closure. The prognosis is worse than primary open angle glaucoma, as IOP is usually higher and may exhibit marked fluctuation. Severe damage may be present at diagnosis and can develop rapidly. In the long term, these patients are at risk of vision loss and blindness. It is therefore important to monitor patients closely, and it may be prudent for review in patients with pseudoexposition syndrome to take place at intervals of no more than 6 months. Treatment. The medical treatment is similar to that of primary open angle glaucoma, but failure is more common. So laser trabeculoplasty is more effective than primary open angle glaucoma, with mean IOP reduction around 30% following SLT. Care should be taken not to apply excessive energy, as trabecular pigmentation may confer higher absorption, resulting in transient IOP spikes. A significant rise in IOP may occur approximately 2 years after SLT. Phacoemulsification alone may significantly lower IOP, though it may give better control combined with trabeculectomy. There is high risk of complications due to poor mydriasis, increased fragility of the zonules and lens capsule, and endothelial deficiency. There is also an increased risk of a post-operative IOP spike, post-operative corneal edema, inflammation, capsular opacification, capsulorhexis contraction, capsular phimosis, and late IOL decentration or dislocation. Filtration surgery in pseudoexposition glaucoma has a similar success to primary open angle glaucoma, and trabecular aspiration alone seems to confer at least short-term benefit and can be performed at the same time as other intraocular procedures.